My name is Professor Arif Herekar. I'm basically a professor of neurology, both adult and child neurology or pediatric neurology. I've been practicing for 40 years now, and it is time for me to pass on the knowledge I have gained over the last 40 years. This is what has prompted this session today. I have already had lectures on various subjects, both for my Urdu speaking or local speaking population and my international friends and colleagues. But today's session will be basically on headaches. Now, this I hope will be conveyed to my friends with whom I'm associated in Africa. It stretches right down 11 countries that I visited. And then, of course, it should go on to some of my friends who are in Latin America and, of course, elsewhere. I hope you have benefited from what we have learned. Every professor's basic requirement is to pass on the knowledge of whatever 3 decades or 4 decades so that the youngsters learn from his experience. This is the basic requirements. This is what I'm trying to do. So we will be talking about headaches, and today I'm going to limit myself or focus myself only on migraine and tension type headache. Of course, there are so many varieties of headaches that one can cover that should be coming later on in the videos to follow. And today's session will be on headaches, which are migraine, vascular headaches, and tension type headache, which are mostly non-vascular. So the question is, how do you differentiate between a headache that is migraine and one that is tension type headache? Now remember, this is very, very important to differentiate between the two. Because if you do not know, if you can't diagnose the type of headache, you will never be able to treat the patient, and you have to do it accordingly. So number one criteria is to investigate and clinically evaluate the patient to confirm the presence of certain symptoms relating to that typical type of headache. This session has also been prompted by the fact that I have been getting patients over the last many years who say that they've had attacks of migraine for a long, long time and they keep on recurring. Of course, now you must remember that migraine is a walk of life. It's not going to go away, but as age comes on, as the arteries harden, the throbbing gets less, and of course the headaches also become less. But it will go with you because it's a familial headache. It's supposed to be sitting on chromosome 19, so it is inherited. If both parents have it, there is every chance that children are going to have headaches somewhere at least once or twice in a lifetime. Some may have it more intense than others. So when does it start? I mean, normally migraine attacks manifest or start post-puberty. But you can have headaches in children which are migraine, where there's a very strong family history. Both parents have it. So what happens is that these patients who come with headaches, the vascular headaches, now remember, this is a vascular headache. Vascular headache means it goes with the pulse, so it's going to throb. And all vascular headaches are going to throb, and these throbbings can be pretty excruciating at times. So remember one thing, that all vascular headaches are going to be throbbing headaches. And you cannot use the word lancinating. Now, lancinating or spasmodic headaches are a little different. I mean, they will come later. So coming to migraine, what really happens is the attack lasts for 4 to 72 hours, but it can go on for days together if untreated. And it can occur on both sides, which is common migraine, and it can occur on one side, which is a hemicrania. Now, hemicranias are less common than the common headache. They are 15% of the total migraine attacks. The patient has severe attacks of migraine, headaches. He may have nausea, he may have phonophobia. The sound feels bad. He may have photophobia. The light feels bad. And of course, quite a few patients may also have osmophobia. So they react to different smells. These different smells, specific smells in specific people are reason for increasing the headaches or their triggers. So it's a throbbing headache, maybe on one side, maybe on the other side, maybe on both sides. Then, of course, it is quite severe. It's so severe that it will prompt you to go to the neurologist or to the physician, who will later on, of course, if he suggests or if he thinks, will refer you to the specific doctor or the headache specialist or the neurologist. So throbbing headaches will definitely have a very, very important impact on one's life, and that is why they are pretty distinct. People ask that what is the major difference? When a patient comes to you, what is the major difference? Now you have to take a good history. Remember, when I started my practice 40 years ago, my professor always said that history is very important. Obviously, there weren't so many investigations. There weren't imaging studies 40 years ago. But of course, now, because of the advent of neuroimaging, people would just go straight for the MRI. But for your clinical practice, when you're a postgraduate, you must ask certain questions. I've just talked about phonophobia, photophobias, osmophobias, but then you must ask them whether it will last for a long time. See, under 4 hours, headaches under 4 hours in an adult are most likely not a migraine. And then headaches that are mild and not disabling. Now, this is very, very important. Disability is an important component of migraine headaches. And the patient, when he has the attacks, is not able to do anything. So he becomes disabled, at least for that span of time, when he has that excruciating severe headache. So these headaches, vascular headaches like migraine, are disabling. They will prevent you from continuing your quality of life. And to maintain a quality of life, you need to treat the patient. Otherwise, whether they are children, they will miss school. Whether they are adults, they will miss work. And of course, let me say something here. In females, I have seen over the last 40 years that females, when they have the attacks and they're very disabled, they won't be able to work in the kitchen. And their husband would say, "Why? What is going on? You have tension, you have depression, you're creating problems." No, they have genuine headaches which are disabling. Most of these headaches will not allow them to work in whatever form they are. They will be flat in bed, they will be vomiting, vomiting, nausea, throbbing headaches, and they will be very irritable. Remember, irritability, of course, is part of both tension type headache and migraine, but in migraine, almost 90% of patients will become irritable and anxious and angry and oftentimes violent. And they won't stand anyone. They cannot go into gathering, parties, get-togethers, because they are irritable, they do not like sound, they do not like light. So their social life is also restricted. So what does one do when he or she has migraine in adults? So I will be telling you about this as to what one can do. But do we have anything else on this? Now, tension type headaches are more prevalent. You see more patients with tension type headache, but these are not vascular headaches. There is very, very little, if ever, throbbing. If someone asks you a question whether throbbing can occur in tension type headache, of course. But what really happens is there's a spasm in the scalp. Now, this is because the neurotransmitters are active. Now, the most important neurotransmitter in spasms and headaches and depression is serotonin, of course. We can talk about norepinephrine as well, but here we are talking about. So what happens in tension type headache? The scalp feels tight. The patient has various symptoms, pins and needle sensation in the head, but throbbing is not there. And the headache is ache. It's basically an ache. So it's mild, it's constant, it can go on. And the important thing is it does not cause disability. We know of women who come to us saying that they have headaches, but they can still work in the kitchen, they can do all the activities of daily living without being disabled, without losing the quality of life. This is a classical tension type headache. It can be provoked by whatever the stigma or whatever the triggers, whether you have domestic problem, whether you have depression because of any eventful depression. All these things are going to cause depression, and depression is going to cause all these symptoms of tension type headache without disability. The individual continue to work. That is why the patients with tension type headache do not report to you so frequently. So when someone is asked, a doctor is asked, what is the commonest cause of headache? He says migraine. It is really not. Migraine is the commonest headache that reports to a neurology clinic. It is not the commonest headache. The commonest headache is tension type headache. So one must remember this, that tension type headaches are much milder. They continue for months together. They can continue for weeks together. Migraine does not normally go over 72 hours. But if you have something that we often label as status migrainous, it can go on for weeks, of course, if you don't abort it with the typical drugs or with the ideal food that you need to take. So tension type headache, you need to give antidepressants. Then you have to give muscle relaxants as well. And obviously you have to give different types of anxiolytics, because anxiety, free-floating anxiety is uncommon. So you have anxiety and depression, they go together. You have to address the issue of anxiety and depression. You have to relieve the scalp tenderness by tizanidine or whatever these drugs are. And then you have to, if they do not get better and the depression is very intense, then of course you go in for psychotherapy. I hope you have enjoyed this. It may have been a little prolonged, but this session is for my friends who are English speaking. We are trying our best to translate my lectures for those French speaking countries. Of course, there are countries that speak Portuguese, and it will be a little more difficult, people who are in Argentina and other places. But Argentina has Spanish. But there are countries where Portuguese is spoken. We will try and translate these sessions in French and Spanish. Hope you've enjoyed it. If you have, I have an educational channel that you need to subscribe so that we continue to update you with our latest videos. Do write a comment. Every comment under the video on the YouTube helps us to improve on the next video. And if you think this is worth it, press the like icon. Thank you very much.